Study is the relationship between quadriceps thickness and radiological staging and clinical parameters in knee osteoarthritis, a pilot study. As we all know, osteoarthritis is characterized by progressively occurring cartilage destruction, osteophyte formation, and subchondral sclerosis, especially in the load-bearing joints. Osteoarthritis knee is the most prevalent joint disorder, which is a frequent cause of joint pain, disability, healthcare expenditure in aging society. An increase in weight bearing of knee joint and weakness in the stabilizing muscles around the joint can accelerate the degeneration of joint. Hence, strengthening program for the surrounding muscles is the main component in the conservative management of osteoarthritis knee. In this study, the relationship between quadriceps femoris muscle layer thickness measured by ultrasound and radiological grading and clinical parameters in osteoarthritis knee patients was investigated. Aim and objectives of this study: to find the correlation between quadriceps femoris muscle layer thickness and radiological grading and clinical parameters in osteoarthritis knee patients, and to compare the quadriceps thickness of osteoarthritis knee patients with that of control group. This study is a single-center cross-sectional study conducted in my parent department, Department of PMR, Government Medical College, Calicut. Study was conducted from February 15th to April 15th of 2025. We have selected 20 individuals with osteoarthritis knee and 20 individuals as control. The study included consenting subjects aged between 40 to 70 with knee pain fulfilling ACR criteria for diagnosis of primary osteoarthritis knee. The study excluded individuals with a history of recent trauma or knee surgery, history of rheumatoid arthritis or seronegative arthritis, history of injection in the knee within past 6 months, any neuromuscular disorder, had performed a quadriceps strengthening exercise in the previous month. In this study, patients attending PMR OPD with knee pain fulfilling ACR criteria for diagnosis of primary osteoarthritis knee satisfying inclusion and exclusion criteria were enrolled. Interview for collection of socio-demographic data, clinical examination with a visual analog scale score and KL grading of radiographs, weight-bearing APU which is taken up to 3 months prior were done. The quadriceps thickness, that is compared to thickness of rectus femoris and vastus intermedius by high resolution real-time ultrasonography at a midpoint between anterior superior iliac spine and proximal end of patella was measured. 20 individuals were selected as control to compare the difference in quadriceps thickness. This is the picture showing the measurement of quadriceps femoris muscle layer thickness. In the second picture, the superficial muscle is rectus femoris and the deep one is vastus intermedius. In a total of 20 patients, 14 patients were female and 6 were male. Mean age was 59.50 with a standard deviation of 6.76786. Mean BMI was 27.85 with standard deviation of 3.59. We have got 3 quadriceps femoris muscle layer thickness values. For controls, we have got a mean value of 18.44 with standard deviation of 2.89. From these values, we can say that the mean quadriceps thickness value for control group is higher than that of the patients, and the mean quadriceps thickness of the affected side of the patients is less than that of the unaffected or less affected side. Pearson's correlation analysis was done. The value shows that there is a significant negative correlation was found between quadriceps femoris muscle layer thickness and duration of symptoms, visual analog scale score at activity and KL grade. And there is no statistically significant correlation was found between quadriceps femoris muscle layer thickness and age or BMI. A similar study conducted in Turkey by Irfan Koka et al. Among 75 patients with a bilateral osteoarthritis knee aged 40 to 65 years showed a significant negative correlation found between quadriceps thickness and age, duration of disease, visual analog scale score and KL grade. These findings are similar to the findings of my study except for the age. So, preventive measures such as maintaining an ideal weight without causing sarcopenia, avoiding incorrect movement that force the joint, prompt treatment of painful conditions that may cause immobilization, and becoming adapted to regular exercise will make a positive contribution to knee osteoarthritis treatment and prognosis. So, to conclude, the mean quadriceps thickness of control group is higher than that of patients with osteoarthritis knee. The mean quadriceps thickness of affected side is less than the mean value of that of unaffected or less affected side. A statistically significant negative correlation was found between quadriceps thickness and the duration of symptoms, visual analog scale score at activity, and KL grade. No statistically significant correlation was found between quadriceps thickness and age or BMI. The limitations, small sample size, and sarcopenia is multifactorial, and difficulty in getting healthy controls of this age group. Thank you.
Not highly we get in patients with osteoarthritis. Is it a cause or is it an effect?
It can be both. Instability of the muscles can contribute to rapid degeneration of the joint, and inactivity due to osteoarthritis pain can also contribute to sarcopenia.
So it is something like a vicious cycle.
So is there anything novel in your study? It is a known fact actually.
We can interpret more objectively.
More objectively, that is only the another thing is in your study how many patients had renuvarum valgum deformities?
Less number.
Is there any correlation between quadriceps other muscles?
Yeah, my questions were similar to that. The Indian population generally has genuvarum as a problem. So most of our Indian patients develop medial compartment osteoarthritis very much earlier than lateral compartment osteoarthritis. So those factors are really important, and like Santosh pointed out, I believe the reduction in muscle mass on the side of on the affected side is primarily due to inhibition of the muscle by pain. That's a neurophysiological phenomenon. There's no way you can stop it as long as the pain continues. Absolutely no way. Okay.
Thank you, sir, for highlighting very important point.